This is a man who has mastered the art of ventriloquism and throwing his voice out. But we're not talking about that today. Welcome to Burns. Okay, burns represent a very unique and complicated form of pathophysiology. When burns occur, it used to be popular to characterize them with regard to degrees, and that was the degree of injury to the skin and then subsequent layers. So you'd hear the terms first degree, second degree, third degree. The newer assessment method is a little bit more descriptive. Superficial partial thickness burns involve the epidermis only, so think of a sunburn. Deeper than that are your deep partial thickness burns, and then going down into the fat and muscle layer beyond the dermis, you have full thickness burns. One of the things I always try to mention to people is that from deep to full thickness burns, there's a change with regards to intact and no longer intact sensory nerves. Deep partial thickness burns, because nociception or painful stimulation is still possible, nerves are still viable enough to send pain signals to the brain. This is not the case in full thickness burns where those neurons have died. So when people think of burn injury, of course they think of injury to skin or the deeper layers around the skin. One of the things you may hear in clinical practice is the zones of burn injury specific to the areas involved. At the center of the burn injury is the zone of coagulation. Tissue is completely burned, no viable cells, charred, molecularly changed, nothing viable. Circumferential to the zone of coagulation is the zone of stasis. This area is injured, but with prompt emergent management, it's also potentially viable. Circumferential to the zone of stasis is the zone of hyperemia, which really represents the largest zone of inflammatory vasodilation and subsequent edema or swelling. As you can imagine, based on the severity and extent of burn injuries, these three zones will be different sizes in different patients. People who go and work with burn patients will have the Rule of Nines clinical assessment chart pretty much memorized, probably within the first couple weeks of working there. The Rule of Nines chart is kind of a quick and dirty way to gauge the total body percentage of burn injury, because knowing that implies certain risks in terms of how morbid and potentially mortal a burn patient's injuries actually are. Burn shock is a form of hypovolemic shock. That is, again, specific to burn injury. So after the burn injury occurs, the inflammatory process induces a large degree of vasodilation and a large degree of edema consequent to the vasodilation. If enough of this process occurs, whereby free water from the vasculature enters into the third space, what happens then is vasculature hypovolemia. That in turn leads to a reduced amount of blood volume going back to the heart. If you reduce the amount of blood volume going back to the heart, guess what? You've also reduced left ventricle cardiac output. You can't just make more blood. Reducing left ventricle cardiac output then results in systemic hypotension. That hypotension may result in inadequate tissue perfusion, the definition of what shock is. So yes, of course, burn injury does involve damage to skin, epidermis, dermis, potentially fat and muscle underneath, but that's not all. Lung-related injury can occur from inhalation of the toxic smoke involved in, say, a house fire or something else. And that then can actually cause a very large irritant to the epithelial lining of the lungs. In some susceptible patients, the inflammatory injury of burn smoke can progress to acute respiratory distress syndrome. Concurrent to smoke inhalation as an irritant and direct injury to the lungs, at that same time, patients can inhale toxic amounts of carbon monoxide from the burn smoke. Carbon monoxide is a well-known poisonous gas that has a high affinity for binding with hemoglobin. When carbon monoxide binds to hemoglobin, guess what can't bind to hemoglobin? Oxygen. Kidney injury from burns involves hypovolemia, the same thing that kind of led us into a state of burn shock, but in this case it's specific to the kidneys. Hypovolemia leading to reduced kidney perfusion, just like dehydration does, reduced kidney perfusion. And reduction in perfusion may then lead to acute kidney injury because the kidneys require a certain amount of circulating blood volume to maintain adequate filtration. In case you're wondering, hypovolemia is, just like dehydration, a form of pre-renal kidney injury. In addition to hypovolemia causing potential kidney injury, protein nephropathy can occur within the nephron due to the protein burden that comes from the tissue destruction of the burns themselves. All those cells die and create a huge mess for the body to clean up. Some of that cellular protein waste invariably ends up in the bloodstream, and the kidneys will try their best to filter it out, but they can only do so much. This may then lead to protein nephropathy, and if things are bad enough, the nephropathy can progress to acute tubular necrosis, necrosis of portions of the collecting tubules within the nephron. Oh Lord, burns can cause what? Skin trouble, lung inhalation injury, carbon monoxide poisoning, injury to kidneys. What can't burns do? I'm glad you asked. In addition to what we've already mentioned, gastrointestinal injury can be kind of a secondary consequence of burn trauma too. The first scenario involves hypovolemia, just like with kidneys. And in this case, the hypovolemia results in reduced perfusion of the gastrointestinal tract, and potentially, because of reduced perfusion, a reduction in gut peristalsis. Remember that your gut always should have these kind of rhythmic waves going along to keep things moving in the right direction. That normal peristalsis requires a constant supply of blood. Reduced perfusion to the GI tract reduces peristalsis and potentially creates a scenario called paralytic ileus, a portion of the bowel that is paralyzed or not moving. And this is a form or a version of bowel obstruction. Think of a conveyor belt that just kind of stops at a certain place, doesn't move anymore, and then things just kind of accrue and collect and collect and collect. The second type of injury that burns can ensue on the GI tract has to do with hypovolemia, reducing perfusion to the GI tract, and then creating gastric ischemia, which results in a loss or sloughing of the gastric mucosa. Remember that the gastric mucosa is very protective of the gastric musculature, smooth musculature, from the effects of hydrochloric acid. Without that protective mucosal barrier, hydrochloric acid can literally burn That was a really bad pun. Let me try that again. Hydrochloric acid can literally eat away at the smooth muscle that makes up the stomach. This ulcer has a very specific name. An ulcer caused through the pathologic consequences of burn injury is called a Curling's ulcer. So do you have a little more appreciation for how complicated burn trauma or burn injury can be? And I didn't even mention the massively increased risk of infection that burn trauma involves in terms of the breaking of the skin and the possible introduction of a whole world of microbes to injured areas of the epidermis, dermis, or deeper. And hopefully by explaining how potentially complicated the pathophysiologic effects of burn injury are, it kind of gets your mind thinking, wow, the nursing care of burn patients must be especially complicated as well. And if you thought that, you would be right.